left to chance. So young women often don't have the option, don't have the option of choosing fertility preservation or what kinds of options they want. I think there's also a lot of misunderstanding about what the impact of doing fertility treatment prior to breast cancer treatment. When a young woman has a hormone positive breast cancer, there's a lot of misunderstanding about what the impact of that will be. And I will talk a little bit more about that when I talk about YAAS. Sexual health is, again, something that like no one wants to talk about. There are, a few clinics across the country. Referrals for treatment may or may not be covered by insurance. So even if someone talks with their doctor about it, they have the options may be limited. So, I mean, I thought this was an amazing statistic that 80% of men with prostate cancer report a conversation with their oncologist about sexual difficulty, and only 30% of women with breast cancer reported the same discussion. So obviously with younger women, if you talk to young women with breast cancer, very few of them have had a provider ask them about sexual health or have options for them. It's the options are limited. And then the last disproportionate burden I want to talk about is one that's not talked about very often, but in this study, which there's a lot of discussion about whether there's a different biology in young breast cancer, whether it's there's something else going on. Is it environmental? Is it hereditary? And in this study, the finding was that young age in and of itself is not an independent predictor of delay in diagnosis of breast cancer, which is one of the reasons for higher mortality and later stage of diagnosis. The presenting with symptoms of breast cancer predicts delay and a higher stage of diagnosis. And when you look at young women, 80% of young women discover the first symptoms on their own. It's not through a screening. Whoopsie, sorry. Yeah. So this has become sort of one of my causes in YAAS, that a disproportionate burden is because there is no screening for young women. And when we talk about screening, cancer screenings, breast cancer screening is one of the big ones. We do a lot of work trying to get women screened, but the truth is that young women are not eligible. It's not effective for them. There are many young women who are screened and their cancer isn't seen in a mammogram because they have dense breasts. So it's not an effective tool. So essentially there is no screening tool for young women with breast cancer. So what that means is that they discover the symptoms themselves, and then they have to decide what to do with that. And they have to make that decision, again, being young, not having a lot of experience necessarily with the healthcare system, maybe being afraid that the doctor is going to say, well, why did you bother to come in? This is nothing. Or maybe being the opposite, afraid that it is cancer and not wanting to be told that. But in the meantime, they're living with these symptoms, trying to figure out what to do. And then they take that first step of making a clinic visit. And so instead of going in for a mammogram and being having pamphlets describing what breast cancer is and being sort of navigated through those initial steps, they're going for a clinic visit, just starting this exploration with a provider who may or may not be comfortable or confident dealing with that. The next step after that is that they're sent for imaging and biopsy. So in the normal pathway, there's diagnostic imaging, and then if there's reason, there's a biopsy, and there's some lag time in there. With young women, what we found is that it happens really, really quickly. That once there's imaging, if something's seen on that imaging, sometimes the biopsy happens like on the same day, at the same, at the same moment. That diagnosis happens really fast. And then they go into diagnosis and treatment planning. So you can see that the pathway through diagnosis for young women is very different than it is for older women. And the reason that that's significant is that when we put so much effort into mammography and screening, there's a lot of stuff that happens that when we promote screening, there's education, and more important, there's navigators who help women through find a find a mammogram center where they can get a mammogram. Then once, if they have an abnormality, help them navigate to the next stage of finding diagnostic imaging and finding them biopsy and making sure that they get into, if they get a diagnosis, getting into treatment. And that doesn't happen with young women because it's just, it's chaos. It's extremely fragmented. And so young women walk into their first appointment for cancer care, having already been through an obstacle course to get the diagnosis. At that point, they're getting information from multiple sources, and it's not necessarily consistent. And what we found, I should have said this at the beginning, this is based on a study that we did, a qualitative survey of young women and their diagnosis experiences, and that it's a diverse population. And when I say that, I'm not just talking about racial and ethnic diversity, but age diversity. So the difference between a woman under 30 and a woman between 40 and 45 getting a diagnosis is different. That experience is very different. What we found, a woman who's pregnant, women who get a de novo metastatic breast cancer. So there's really a need for customized messaging to support young women through that process. And very little of that exists right now. And the last thing that I'll say to this group in particular is that women rely really heavily on the guidance of their healthcare providers at this point. If they go in for that initial visit and the provider says, oh, you're too young to have breast cancer, don't worry about it, come back in 6 months and we'll see if it's still a problem, they will believe them because they want to believe them. The flip side is there are women who don't believe it and they go find another provider and they keep looking for a provider until somebody evaluates them and they get a final answer to that. But what we found is that providers are often not prepared to deliver appropriate care. One of the most I think it's one of the most powerful stories in that research and diagnosis is a young woman who went to her usual provider, and the provider said, oh, I'm sure it's nothing, but let's go ahead and get you checked out. We'll send her for imaging, and told her over and over again, don't worry about it. I'd be really shocked if it was breast cancer. And when he had to call her and tell her that she had a cancer diagnosis, he cried, and she ended up comforting him because he was so upset that he had told her that it wasn't cancer, and then he had to deliver a diagnosis. So in response to this, the CDC put out an FOA for multiple approaches to support young women cancer survivors and metastatic breast cancer patients. And the purpose is to increase availability of supportive services. So we responded to that RFA, saying that we know that there's a lot of resources that exist to build a sustainable collaborative platform to build wraparound support and resources to young women. And so that was the goal that we proposed to the CDC 4 years ago. And the CDC gave us 4 objectives: to establish a network of clinicians, scientists, survivors, caregivers, to facilitate policy, system, and environmental change. So the CDC said, we don't just want you to move the needle for the women who are immediately involved in your program. We want you to move the needle. We want you to make changes in policy, system, and environment so that those changes are sustainable over time. The second one is educational opportunities for healthcare providers. The third one was education and opportunity and awareness for survivors, caregivers, and providers. And you'll see that they want innovative technological approaches, which is, sort of what everyone does now anyway. And then the last one was to utilize patient navigation and community health worker programs to reach underserved populations. So the goal of our program is just sort of to create this wraparound protective safety net circle around survivors, thrivers, which is the name that young women with metastatic breast cancer typically use, and co-survivors or caregivers. We created our project administration over the top, and you've met all of us except for one. Our research intern, Sarah Strom, is still in Denver at the American Public Health Association meeting. And then a panel of survivor experts. We've recruited 5 experts, different diagnoses, different backgrounds, different experiences, to sort of inform everything that we do at the project, and then trying to connect the dots so that young women don't have to, so that a young woman can enter this at any point and be connected with all of the other services around the circle. Our YAAS network has community partners. We currently have, so we started with 5. We added another one, we added 2 in the second year, Immerman Angels and the Breast Cancer Resource Center. Breast Cancer Resource Center is in Texas, and I will talk about their role later. Unfortunately, this year we lost one of our partners who made the decision that they were doing broader than breast cancer, and especially broader than young women with breast cancer. We have 6 women on the expert panel. There's been 1 swap on that as well. And then we have a team of people from UIC and UI Health, and I hope that I didn't forget anyone. And again, there's been some transition on that, but that's the core group of people. So we started with an environmental scan, which again was a decision made by the CDC. They asked us to do an environmental scan. So we cataloged the resources that are available to young women affected by breast cancer, and we looked at a gap analysis. And one of the biggest findings from that, we conducted a participatory design workshop with all of our partners and had them talk about their role and their connection to others. And what we found is that comprehensive services are often available in a comprehensive cancer center or in a academic medical environment where resources are in the same space, not always as connected as we would like them to be. And then community organizations tend to be siloed and to provide services within their sort of area of expertise and often within their geography, and that they're not very well connected. And I know that that is an exception here, that Wellness House and Immerman Angels and other programs are embedded in our cancer center, but that is not the case for many of the women. So for example, if you are not at a particular hospital, you may not have access to the resources. So they could develop a really great young women's breast cancer program, but if your insurance isn't covered, if it's far from your house, or if it's not where you want to go, if you choose a doctor who's not at that cancer center, you will not have access to those resources. So being aware that there's a connection, the connection issue is huge. We looked at SEER data, which was national data, to try to understand better our population. We're focused, from the beginning, we were focused on with a health equity lens, looking at young women of color and young women who are low income, refugee, immigrant populations. We were looking at anyone who might be isolated or lacking resources once they're diagnosed with breast cancer. So the SEER data showed what I talked about earlier, that there is really significant racial disparities in survival based on tumor type and cancer stage. But what it showed was really surprising to me, and this data has now become much more, it's becoming much more well known. But the disparities are higher with the women who have hormone positive cancers. And the reason that's significant, because it's often talked about that, for example, Black women have higher rates of triple negative cancers. But the most common cancer across the board is hormone positive cancer, and those cancers have pretty effective treatments. And so that disparity is really disturbing, because what it shows is that there's a disparity in access to care and access to medications, not necessarily in some racial biology of the tumor. The BRSA data, which the CDC relies on because it's their data, Illinois is not great about our BRSA data for cancer survivors, but we found disparities by income, and that's quality of life and behavioral risk factors, income, education, marital status, and activity levels. And then the qualitative survey of diagnostic pathway, we found that, the fact that there's no effective screening was really significant, and that health providers play an even more critical role for young women than they do for older women. So we started in October of 2019. We had this beautiful 4-quarter plan laid out, and then we got hit with a global pandemic. And our entire plan was to be in the community, on the ground, meeting with people. And of course, that just came to a screeching halt. So we had to do what everybody did, which was to pivot really quickly and try to figure out, not knowing at the time that we were going to be in lockdown for over a year, try to figure out how we were going to continue to do this work without being face to face with people. Okay, so I'm out of, sorry. So this is out of order, so I apologize. So I'll just jump into this. So if you remember back, we talked about the 4 things that we were doing. So I've already talked about the creating a network to connect people. So in provider education, during the first year, we kind of put that on hold, knowing that providers were really kind of, their attention was elsewhere and that we didn't want to add to that burden. You know, young women were still getting diagnosed with breast cancer, but at a much slower rate, as we all know that diagnoses really slowed down during that time, and we're kind of paying the price for that now. But what we ended up doing in our second year is to develop in our innovative technological mode, video shorts focused on delivering care to young women. And since we have such an amazing team here at UI Health, we called on our team internally we've created 7 videos. We have material to do many more than 7 shorts, but the idea is to do short videos that can be watched, you know, in 5 to 10 minutes between appointments, or, you know, while you're sitting and waiting for something to happen, that just talk about, you know, coach a little bit about how to work with young women and to raise awareness of the kinds of burden on young women and to give people the language to talk to young women. We've also done presentations at conferences. I co-presented with Dr. Ganschow at a provider meeting, hoping to do more of those grand rounds, just places where we can share some of this, you know, as a reminder, and also raise awareness of the resources. There's also a lot of provider education. So the CDC funding went to 7 different sites, and all of those sites have been charged with doing provider education. So we are connecting people with those resources, as well as our own partners. Triage Cancer does some amazing training. Their insurance and finance intensive is a full day workshop, and they spend an hour talking about Medicare or Medicare. They spend an hour talking about the difference between deductible and out-of-pocket costs, and how to calculate things so that you get the best value from your insurance. They talk about work accommodations. So those are some of the ways that we're promoting provider education. We have 3 more years in the grant, and if people have suggestions about other innovative ways to reach providers, we would be happy. We had originally thought about doing a virtual learning collaborative, and we were discouraged from doing that it was a bigger commitment than providers could take on, and certainly now in the current climate, it's definitely too much. I do want to tell you about an event that's coming up in December. Registration is just opened, and you may have already gotten an email about it, that we're including, and we're especially want providers to participate in a leadership in cancer advocacy training. It will be led by Triage Cancer. It's a 3-hour workshop. It's split over 2 days, an hour and a half each day. But the idea is that, you know, advocacy is often focused exclusively on or heavily focused on patients, and that patients have, you know, sort of have the best story to tell to try to move the needle on policy. But what we found is that providers have really powerful stories about the kinds of things that we talked about, the disproportionate burden and the barriers to delivering care because of insurance or because of other obstacles. And then at the other end of the spectrum, scientists who are working in labs who are developing treatments that are not able to, that young women aren't able to access, again, because of insurance issues or because of out-of-pocket costs. And so what we wanted to do is bring everybody together in one room and sort of create that entire story, to create that entire continuum, give everybody the tools to tell their story as part of that bigger picture, and to identify places to advocate, not just legislative advocacy, but to advocate within your organization, within your community, and even to advocate for yourself or a patient. In the outreach and engagement area, our goal is to increase awareness. We have most of our outreach and engagement is done with our community partners, to create a welcoming and supportive environment for young women. And when we started, the numbers were very small and there weren't very many events that were specifically for young women or even recognized that young women might be attending. And that has changed pretty dramatically among our partners. We have hosted off and on monthly social events for young women in collaboration with Wellness House. We just recently completed a mindfulness self-compassion training for young women, young African-American women. There's our community-based organization sponsored support groups and events, and then social media. And you can follow us, please, on any of our social media. We try to promote resources through that. One of the interesting things, we've just started a new campaign this month. We found that what our expert panel told us is that they get a lot of scary media, or what is it? Just the shock of, young women die more quickly, young women don't have access to resources. And they said they really don't want to see that. They want to see supportive stuff. They want to see stuff that is going to provide resources and provide them some sort of direction or comfort or connection to other young women. And so that really is the goal of our social media campaign. This is just sort of our community-based organizations are amazing, our partners, and these are some of the events that we've done. We've done an event called Survivor Meet Survivor, where we brought African-American survivors together and broke them down between young survivors and mature survivors, and asked them to share their experiences across that gap, because young survivors often feel like they're not heard, and women over 45 often don't even recognize the reality or say, oh my gosh, I can't even imagine what it's like to be diagnosed as a young woman, but they don't talk to young women about it. So we're very fortunate to have all these resources in Chicago and to have partners who are so enthusiastic about doing this work. So the last is patient navigation. And as I said, we know that patient navigation is effective for screening. It's now sort of the standard of care. It's a model that is well known and well received. And as I said, that we started with screening, and I got cut off, abnormal finding to diagnosis, et cetera. And community navigation ends at diagnosis. They navigate people into treatment, at which point the hospital takes over with clinic navigation, oncology, social work. And then it ends when treatment ends and you get a survivorship care plan and you go into survivorship. And as we know from the research, that a lot of women feel like that they fall off a cliff, that like treatment ends and they've been going in for treatment on a regular basis, and they feel like they're doing something about their cancer, and then treatment ends and they're not really sure what they're supposed to do and whether or not they have a survivorship care plan. So our proposed model for our patient navigation is to get rid of the idea of the survivorship care plan and sort of get rid of the idea of survivorship as something that starts when treatment is done, and move that as surveillance, and then bring survivorship to encompass the entire process using the NCI definition that women are, you become a survivor when you're at the time of diagnosis. And then bring community navigation, people trained in survivorship to do a warm handoff from the community navigators who do the work of screening and educating the communities, but have a warm handoff and have those community navigators ready to navigate women to services that they may or may not have been offered in the clinic. And again, it sort of depends on where they get treated. We know there's a lot of community hospitals in Chicago, and some of them offer treatment for young women diagnosed with breast cancer, even though those hospitals may not be very well equipped to do that. So based on that model, we built a virtual learning community to increase capacity for community-based survivorship. And that was the model that Debbie mentioned at the beginning, the extension for community health outcomes. This is sort of that model of using a virtual learning collaborator. We launched a pilot in January of 2021. It's a 14-week series that meets once a week for a 16-minute telehealth session with a 20-minute didactic and then a community-based presentation of a de-identified patient case. And we're collaborating with the Breast Cancer Resource Center in Texas. They have a breast survivorship health educator who's fantastic and who's led this series for us. And then we have guest appearances by many of our colleagues at UI Health. And then Facing Our Risk of Cancer, Empowered Force, many of you know them for their hereditary cancer work. They give a talk about hereditary cancer and genetic testing. And as you can see, here's the list of topics. And on the right-hand side is a cut from the case presentation. And the reason that I bring that up is because we do pay the community-based case presentations, they're de-identified. But the reason that we do that, and a lot of people say, oh, you know, I'll just do my own case. But what happens when the presenter or the facilitator provides the case is always neatly wrapped up. It always has like, I did this and this and this, and everything turned out well, or if it didn't turn out well, it was the exception. And what we know is that in the community, like it's really hard to have a nicely wrapped up, all the loose ends wrapped up. And there's a lot of factors that come into play. So when you have a community-based case, you actually have to do active problem solving. And so there's a lot of work of trying to figure out what the options are. And we use the expertise of the facilitator, but also of the community, the people who are working in the community who know about resources and know about the community and know a lot about the communities where they live in, to bring that expertise as well to the conversation. And this particular case was a young woman who was diagnosed with metastatic breast cancer and was refusing treatment. And the end result of that case discussion was that there wasn't really a good solution other than to support her in that decision and allow her to move forward with that. That this person had done a lot to try to change that, but what she needed from the group at that point, instead of more resources, was support to say, yes, you're doing the right thing, you're doing the best that you can, and the outcome of this is going to be what this one young woman chooses, and it's your job to support her in that. So our lessons learned to date, this is just the top 5. One of the things is that young African-American women in low-income neighborhoods are invisible. And that is true to everyone. In our outreach, we've reached out to churches that have breast cancer support organizations, and they say, oh, we have no young women in our group. We've talked to people who are doing in African-American communities doing breast cancer work. The young women are there. They kind of come into vision and then they kind of fade away. We know that they have a lot of competing priorities, and it's really challenging for them to connect with breast cancer support resources. Much more so, there's a really pretty robust, I'll Ask Wings has a pretty robust young survivor group, and it's sort of driven by the young women themselves. That's not happening in the African-American community, and we really want to work to change that. That's become one of our primary goals for the 5 years, is that we can build a critical mass base where young women know that exists and figure out a way for them to get connected. We would consider this project a success. As I've mentioned, that resources exist, but they may not be offered. Young women may not learn about them. They may not know that they exist, or they may not even recognize that the problem that they're having is a problem from cancer, not something that is their personal. I mean, financial toxicity is one where women feel very isolated and don't want to necessarily share with anyone. Care is fragmented, and that the burden falls on young women to overcome that fragmentation. Online engagement can work with this population or this community, but it's really difficult without face-to-face interactions. It really helps to have both. Once people know each other, they become more comfortable online. And vice versa, when people meet online and they get along, they want to meet each other face-to-face. And then the last is that the diagnostic pathway really matters. And it's something that we don't see discussed very much, but it's become, like I said, a crusade for us that to recognize that breast cancer screening is for women, who knows, 45 and older, 50 and older, whatever the guidelines happen to be in the moment. I've already introduced our staff. I also want to thank Ria and Erica and Courtney and Sheridan, who've all played a role in grants. And I'm sure that there are other people. C has been incredibly supportive. This project is, would not happen without a lot of people playing roles. As I say, we're a small but mighty team. And then the last thing, I just want to invite everyone on the call to join the YAAS network in whatever way you see appropriate. I want to again promote our leadership in cancer advocacy training because I really want provider and scientist voices in that room. I think it's important for patients and caregivers to hear those stories and to know that they're not fighting this battle alone, and that there are other people recognizing those barriers and fighting alongside them. We invite you just to subscribe if you're not already a subscriber to the YAAS monthly newsletter, where we share information about resources and activities. Follow us on social media. If you're interested in being part of the virtual learning collaborative or the provider education videos, please let us know. We are happy to collaborate with whoever. We're a very collaborative group. And then the last thing is, if you have young women who are diagnosed with breast cancer, please share our information with them. Because of HIPAA, we're not allowed to move, identify, flag a young woman and move in and sort of be there to support her. And so we're counting on people who are patient facing and in the clinics to connect young women to those resources and make sure that they're connected to another community. And the last thing that I'll say, the significance of that, and again, people who work with patients know this, that peer support is incredibly important. And I actually left that off of the findings from the survey, that young women turn to peer networks just to be able to see someone who, like them, who's in a similar situation. Because when they go in for chemo, when they go in for treatment, they don't see other young women. The numbers are so small that they don't. And so getting them connected to each other is a really important part, not only for support, but it's a way that they share tips and tricks about, a cold cap if it's not offered to them, or what to do about, a spouse who doesn't understand what you're going through. So I thank you all for listening, and I'm happy to answer any questions.
Tamara, thank you so much for that wonderful talk, telling us about this wonderful resource for our cancer survivors. It's just an incredible program that you have put together with your team. And we are so glad that you're providing this service. It just fits in perfectly with our paradigm in the survivorship clinic, providing support, providing wraparound resources to patients, and really letting patients know they're seen, right? And just being able to connect them to those resources is so important. Especially a big one I like is the peer resources, and connecting them to all those support groups and to each other, because they thrive on that. And when I meet a survivor who doesn't have that network and I connect them, they just light up. So it's really an amazing, amazing thing. I know one thing I had a question about that you talked about. I know we don't have great ways to screen young women for breast cancer. We only go down when patients have BRCA down to age 30 with MRIs, and even that's not super. And I remember Dr. Ganshow in my residency, telling me, well, mammograms kind of suck, but it's the best we got. Mm-hmm. And so I don't know if is there an emerging field? Is there something new on the horizon for screening to try to bring better better ways to find cancer in younger populations to women?
So it's something that I'm just starting to look at. I have not found anything yet. I mean, I've talked to one person who was looking at sort of 3D imaging that might work better with young women. And of course, things like liquid biopsy have a lot of potential for that exact thing. But at this point, you know, one of the things, and it kind of makes me cringe, is, you know, pushing for mammograms for women who are younger. And in our study, I can't tell you how many young women had a mammography. They found a lump, they were sent for a mammogram, and the mammogram showed there was no sign of cancer, and they were sent home. So it's not a very effective tool for women with dense breasts and just young women. So even when they're sent, even if mammograms were available, which they should be, and there shouldn't be no insurance burden, especially if there are symptoms, it's not an effective tool. I mean, I don't remember the statistics off the top of my head, but even for the general population, you know, it's the best tool that we have.
Yeah.
So it's one of the things that I'm starting to look into to sort of see around the country what is going on. But I think that there's not a lot of attention to it because everybody thinks, well, we have a screening tool for breast cancer. Let's look for a screening tool for cancer that doesn't have, you know, that doesn't have an effective screening right now. And so it's completely admissible that 10% of the population just doesn't have a screening for breast cancer.
Right. If we only have our guidelines to go on primary care, and misses a whole lot. So hopefully we'll continue to work developing those methods and developing the support resources for these patients so that young women can advocate for their care, right? That's a large part of all of this is, I tell my patients all the time, if something needs to change or you're concerned about something, you need to tell us. And it empowers your programs like yours, empower these women to bring things up to light and to bring things up that no one wants to address. So does anyone else have any questions for Tamara? Just a lot of praise in the chat and links to the leadership in cancer advocacy training. Definitely plugging that. Thank you, Talia, for sharing some links. And getting involved with YAAS, with triage cancer. These are all things that we kind of try to keep our pulse on so that we can participate in, and definitely sign up for the newsletter because that's super easy to do and it comes out to you. There's so much enriching information in it. So with that, I guess we're a few minutes early. Does anyone else have any other comments for Dr. Hamlish or the YAAS team? Any stories anyone wants to share that might uplift our days further? All right. Well, thanks everyone. Oh, Christiana, I'm sorry. Dr. Shrestari, do you want to speak?
I was just invited to this by Dr. Crenshaw yesterday. I talked to her, but I just, so I'm a former UIC medical student, but I am finishing up my internal medicine training at Lutheran General. But I was diagnosed with breast cancer last year at age 38 years old. And I just wanted to say that every single part of this presentation is, I thank you as a survivor. This is exactly what we need. I've a lot of personal experience about my frustrations, even as a physician navigating the system and how fragmented it is. And I cannot even imagine those that don't have the health literacy, the resources, the access, the education, how they even able to manage this. So I just wanted to say thank you and for what it's worth, and very excited. And I've been texting, messaging Talia, like, I want to be part of this and see how I can help. And I've extensive advocacy work. I used to work in the Senate. I've done policy work. So yeah, that's all. I just wanted to say thank you.
Okay, well, as long as Talia has your information, like I was gonna say,
Yeah.
like, okay, we want you. No, I think that it's one of the things, and I didn't mention this earlier, but I am I'm an old young survivor. I'm a 17-year survivor. And everything that was in the presentation are things that I experienced. I mean, I had a mammogram. I still have the letter that I went home, the lump I could feel that said, "You're fine, come back in a year." And I had an extremely aggressive, I had a 9-centimeter tumor that did not show up on a mammogram. So when women are sent home, I mean, I went back because this just makes me uncomfortable, but I think about the young women who would say, okay, well, the doctor told me no, and I don't know where else to go, and I don't know what else to do. Those women show up with stage 4 breast cancer.
I goosebumps, and I also accidentally felt mine. And I mean, your story is, I know it's out there, and I feel fortunate. My husband's a surgery resident at U of C, which is where I got my care. And I felt it accidentally, and it was very deep. I'm big breasted, as 3 centimeters. But I think because we kind of know what's unusual. I mean, I think if you're not aware of that, what should feel normal, and we just watched it on our own for a couple of weeks, it was still there. And I think because we're physicians and we asked for it to be examined, was probably one of the only reasons I got a mammogram. So absolutely, it's so saddening to see how many have stage 4 at such a young age. And I'm part of a lot of like private networks, and it just brings me to tears. And I've virtually met a lot and some have actually died since then, since meeting them this past year. So yeah, thank you again for your work on this. And I'm really excited and so thankful that this is out there, because I couldn't find anything this past year. And I'm thankful to Dr. Grenshaw, and then to another individual who connected me to her.
Well, we're really happy to meet you, and thank you for being open about your story. I think that's one of the ways that we raise awareness.
Yeah, we'd love for you to be involved. Cancer Center with survivorship and with YAAS all across the board. Your story is awesome. And yes, it's out there. My sister was 8 months out of a mammogram at 45 and, felt a lump, and she took initiative. She went in and she was diagnosed within the week. It's either neck, but she would have loved to have a resource like this, because I'll ask her, like, what existed, what kind of resources. And another challenge of something like this too is, like, this is planted, like you said, in an urban, academic center, but outreaching to the greater metropolitan area, to the rest of the state, what exists for cancer survivors in Bourbonnais or something like that. And so connecting with those individuals, especially online, is great, but trying to reach them, because she was in the LA surrounding area, and it would have been great for her if there were online resources, which COVID has brought, opened our eyes to some of that. So great. I'm glad we're making connections here, and thanks everyone for coming. It is 10, so we'll sign off, but if you have any other questions, email myself or Tamara. Sure, we're glad to take them. Thanks, everyone.
Thank you.